to inform you about our next meeting also, which is scheduled on June 7th. And our next speaker is going to be Dr. Ivan Wu from UCSF, and she's going to talk about the HEAL trial. As you know, this is the erythropoietin used in infants with HIE. And for this meeting, you can type your questions in the chat box anytime. And Dr. Pressler is going to answer your questions at the end of her meeting. And it is my great pleasure to introduce our speaker today, Dr. Ronit Pressler. And Ronit is consultant in clinical neurophysiology at Great Ormond Street Hospital for Children at Cambridge University Hospital and associate professor at UCL Institute of Child Health. Her research interests include neonatal seizures, particularly their diagnosis and treatment. She has chaired a number of international task forces and working groups on neonatal EEG and neonatal seizures, including the ILA Neonatal Seizure Classification Task Force and ILA Neonatal Guidelines Task Force. Ronit.
Thank you very much for your invitation to present the latest task force, the results of the task force. So basically, this is the work we have done over the last few years with the ILAE Neonatal Task Force. So I'll just show you my disclosures, but none of these should have had any influence on the data I'm going to show you today. The learning objectives, hopefully you'll understand the challenges in diagnosing and treating neonatal seizures. You should be able to recognize the need for standardized treatment and the principles of and you should understand the principles of the new ILAE guidelines. So just as a way of introduction, neonatal seizures are more common, or seizures are more common in the neonatal period than in any other time in life. But most seizures are acute symptomatic, so they're not part of an epilepsy syndrome. They are a response to acute brain injury. And in term babies, hypoxic ischemic encephalopathy is the most common cause. Other important causes are vascular infections, and brain malformation, genetics, and metabolic are common causes for epilepsy syndromes, but only like 10–15% of all seizures are the beginning of an epilepsy syndrome. One of the biggest challenges in neonatal seizures is that the clinical diagnosis is unreliable. And I've got two videos here. One is here, a baby with a focal clonic seizure. And even though this is very clearly a seizure because it's focal clonic, you can imagine how difficult this would be to diagnose in an ITU setting. Somebody has to really look very carefully and obviously observe the child also for a prolonged period to see this. On the other hand, you have episodes like this, where you have a baby in an ambulance treated with phenobarbital and phenytoin and now transferred to a tertiary referral center, and in the ambulance has this jerking movements, now treated on top with third-line medication with oxygen, because everybody's convinced that these are seizures, but in fact these are sleep myoclonus. But from a clinical, the clinical semiology is really very similar to epileptic myoclonus. So all this really means is that the clinical diagnosis is unreliable and you need EEG or AEG to confirm whether something is a seizure or not. We also know that therapy or treatment is challenging and difficult, and obviously this talk is in mostly about therapy. But before I talk about therapy, I want to briefly mention outcome. So we know that neonatal seizures are associated with poor outcome, and this is mostly due to etiology. Etiology and comorbidity definitely play a very important role. There's no question. But there is also socioeconomic factors, and there are more and more studies showing how important that is. And anti-seizure medication can obviously also affect outcome, although the evidence for that is not that clear. The question always is, how much do seizures add to poor outcome? So can a high seizure burden or status epilepticus add to a poor outcome and worsen outcome over and above what you would have from the etiology alone? And over the last few years, a few studies have been showing that if neonates have a high seizure burden of more than 12 minutes per hour, then that is independently of etiology associated with a worse outcome. Other studies in the past have always shown that status epilepticus is associated with worse outcome, or in itself causes worse outcome. But now we know that even 12 minutes per hour, a seizure burden of 12 minutes per hour clearly makes a difference. The question is whether the early diagnosis and treatment would improve outcome. And obviously the only way to prove this is that if you have a big cohort of babies and half of them you treat and the other ones you don't treat, and you see whether that has an effect on outcome. But that's not ethical. And neither the EMA nor the FDA would allow placebo-controlled trials. They have clearly said this a number of times. And so we can't do this. But there is some indirect evidence that actually early diagnosis and early treatment can reduce the seizure burden and therefore improve outcome. So it's really indirect. But basically, these studies here have all shown that if you implement AEG and treatment guidelines, and thereby have diagnose early and treat early, that can overall reduce the total seizure burden. So what these studies found is that with AEG, with continuous EEG monitoring, you can improve the early diagnosis and the early detection. All of these studies found about seizures in about 20 to 30% of high-risk infants. But if you diagnose early, then it seems to have an effect on treatment success. So the Harris study and the Wustov study both showed that if you diagnose early, you have a better success rate in seizure, in reducing seizure burden. There was definitely less progression to status epilepticus and overall a shorter stay in NICU and a reduced number of infants discharged on anti-seizure medication. In particular, the study by Courtney Wustov showed that if you screen for seizures rather than do confirmatory EEG monitoring, that has an effect on you have a higher treatment success. So basically what that means is that if you diagnose early and treat early, you can reduce the seizure burden, and hopefully then indirectly that is an indication that that treatment would improve outcome. So how do we treat neonatal seizures? Well, there have been a number of surveys looking at what people use, what neonatal units use as first-line medication. And as you can see over the years and in all countries, phenobarbital is used first line. And this is still the case. There was a brief period where in some countries levetiracetam was used first line, but I think this has changed now again. Second line is very variable. So some countries and some units use levetiracetam, others phenytoin, benzodiazepines, or lidocaine. So phenobarbital, the most commonly used anti-seizure medication for neonatal seizures, but how safe is it and how effective is it? What you can see here, this shows you the different anti-seizure medication which have been developed for seizures and epilepsy over the years. And you can see phenobarbital was discovered in the late 1800s, but then first used for seizures and epilepsy in 1910. Since then, we have a number of medications developed for adults and children, but nothing really for neonates. So we have still used a drug which is from 1910. And there are quite rightly concerns about its safety. We know that it causes respiratory suppression, and in some neonates you have need for ventilation. Some babies need cardiovascular support when they're on phenobarbital. There is the phenomenon of electroclinical uncoupling if you use phenobarbital. So it can cause seizures to become electrographic only, which means you need EEG monitoring to really see whether the treatment was successful. And finally, there's some concerns about an increase in apoptosis. These are the studies by Bittigau and Kim. But all of these were done in healthy animals rather than in animals which have epilepsy or seizures. So it's not quite clear whether the increase in apoptosis is really relevant in if you reduce the seizure burden and avoid status epilepticus. But this is an open question. We really don't have any good animal models and definitely no data from humans. How about response to anti-seizure treatment? So there was one study by the US Neonatal Registry where they enrolled nearly 600 babies in prospectively, over 600 babies, but in this analysis, they included 534 babies. And what they found is they found an incomplete response in 66%. So only less than a third of babies responded to treatment completely. And the responsiveness was really independent of gestational age, gender, choice of drugs. So phenobarbital, phenytoin, and levetiracetam. The incomplete response was really very similar in all of them. And so also independent of etiology, although there was overall a better tendency for seizures to respond to HIE rather than to vascular etiologies. But even though this was prospectively enrolled, this was a purely observational study. So what do evidence-based, or what does the evidence show us? So there have been a Cochrane review, which was published in 2004, and the WHO-ILAE Neonatal Seizure Guidelines, which were published in 2011. And they looked at all the evidence and found only 2 studies with adequate outcome measures and good enough methodology to be included into their reviews. And both of them said there's little evidence to support the use of any anti-epileptic or anti-seizure medication. And the ILO, the WHO guidelines said only phenobarbital can be recommended, but with very low evidence. So this was really an expert recommendation rather than the evidence. So that makes it a bit difficult, and it really doesn't help. So what we did, the ILAE task force worked on an update on these guidelines, and actually the Cochrane group is also working currently on an update on their review. The ILAE guidelines, so it's a systematic review plus guidelines, whereas the Cochrane report obviously is only a systematic review and meta-analysis without any expert guidelines. So what we did in the ILAE task force, we did a systematic review, meta-analysis, and an expert recommendation. And we followed the ILAE guidelines for guidelines, which was first published in 2015 and then updated just last year. And so these is the way what what we had to do. So it's a very clear process which we had to follow to develop these guidelines. And I'll try to talk you through these. So first, we formulated 6 priority questions around the treatment of neonatal seizures using PICO. And these are our priority questions. So what is the best first-line anti-seizure medication? What is the second-line anti-seizure medication? When to stop anti-seizure medication? What is the effect of therapeutic hypothermia? And this question was never asked before because obviously cooling has only recently come in as standard of care. Should we treat electrographic seizures? And also the question about pyridoxine and pyridoxal 5-phosphate. So then we build up a working group, international and multidisciplinary working group. And really we included neonatologists, neurologists, pediatricians, neurophysiologists, and methodologists from all over the world. We also had a patient representative. And then we went on to identify the evidence. We screened 2,500 abstracts and then finally included 218 papers. And these were our selection criteria. So we went since 2004, 7 languages, only human studies, more than 5 patients, and the paper had to address at least 1 priority questions. And for efficacy, we only included studies which used EEG for the diagnosis of seizures. And these are all the studies we included. So you can see this is the number of studies we included per priority questions. It was a lot of work. And then finally, we evaluated the evidence using GRADE, but there were only really 3 priority questions where we had evidence from randomized controlled studies available. So for all the other priority questions, where either there were no randomized controlled studies or when the results were inconclusive, we did expert recommendations using a Delphi process. And we did a total of 3 rounds. And then finally, we formulated the guidelines. And at the moment, we've done all of this, and the guidelines are now with epilepsy and hopefully will be published at some point. In between, actually, there was also, so we formulated the guidelines and then we had an public consultation. So the guidelines were on the internet for 4 weeks, and we asked experts to comment, and then we implemented all the changes which were suggested by this public consultation. So what I want to do now is go through the priority questions one by one and tell you what the results of our systematic review were and the Delphi. So first-line anti-seizure medication. We included 11 studies, but only 2 of these were randomized controlled studies, the Painter study and the Sharp study. So Painter, I'm sure you're aware of this study, compared phenytoin with phenobarbital first line, and if the babies didn't respond, they were added on phenobarbital, so phenytoin add on phenobarbital, and phenobarbital group add on phenytoin. And what you can see that with first line, 45% of babies became seizure-free with either drug. And the certainty was low because the babies were not really well equally. There was a difference in the sex, and they also didn't really give enough didn't show enough of their raw data, how high the seizure burden was and how it was reduced. But the evidence was good enough to do a grade, but there was no difference between phenytoin or phenobarbital. The Sharpie study was the second randomized controlled trial for first line. So there are really only 2 randomized controlled trials for first line. And here in the Sharpie study, they compared levetiracetam with phenobarbital. This study was initiated with the idea that everybody thought levetiracetam will be much more effective. So the way they set it up was that 2/3 of babies received levetiracetam and only 1/3 phenobarbital. The advantage with this study was that they monitored EEG with EEG high-risk babies. So they started treatment as soon as seizures were detected very early. And what you can see is what they found is that they had seizure freedom in 21% with levetiracetam with the first dose and in 70% with phenobarbital. If the second dose was given, you have 28% of babies responding to levetiracetam and a total of 80% with phenobarbital. And that is really very, very different to the Painter study or what other studies like the GLASS study also show. And the reason why people think that in the Sharpie study phenobarbital was so much better is that they treated very early. So they had EEG monitoring and screening rather than treatment after the seizures had been established. The certainty is moderate, which is very good for neonatal studies. So then we also did a Delphi. We wanted to see whether if you have babies with a channelopathy, experts would recommend to use sodium channel blockers. So babies with channelopathies, KCNQ2 or SCN2A, we know that sodium channel blockers are very effective. And we asked in the Delphi if it is very likely that a channelopathy is the etiology for seizures due to a family history, then sodium channel blockers should be first line. And all of them agreed, or most of these experts agreed. So we have a high level of agreement. We said agreement is there if you have more than 66% completely or mostly agree. And you see that over 90% here agree. However, this is only if there's a family history. Without a family history, we don't recommend to use sodium channel blockers. Then there's still phenobarbital should be first line. How about second line? Now, we included 22 studies. We have 3 randomized controlled studies. The Painter study, again, because remember, second line was then the other drug. Then a trial by Geraldine Boylan, which we did at King's College Hospital, where we used lidocaine versus midazolam as second line. The problem is that the numbers were very low. And then also Sharpie did also they crossed over babies or they added on the other drug. But again, the numbers were very small. And so all of these studies, the certainty is very low. And therefore, we couldn't do grade analysis. So here we did a Delphi asking if which drug, so here's which drug should be used, phenytoin, levetiracetam, others or no judgment, a second line after phenobarbital. And we asked these questions several times. We discussed it. We specified what the etiology was or without any specific etiology. And basically, we could not agree on anything. We had 3 rounds. We discussed it, and we could not agree of or more than 66% of us could agree on which drug should be used second line. We also tried midazolam or lidocaine, but there was no agreement. So at the end, we had to say that any of the drugs can be used, phenytoin, levetiracetam, or midazolam, or lidocaine, and that there is at the moment no evidence which one of this is preferable. The only difference is that if a baby in a neonate with a cardiac disorder, we all agreed that levetiracetam should be second line. And this is because phenytoin and lidocaine are cardiotoxic. So if you have a neonate with a cardiac disorder, levetiracetam is second line, should be second line, but all other, we don't know. There's no evidence. The other exception is if seizure semiology, EEG, and clinical presentation suggests that this baby may have a channelopathy, even in the absence of a family history, then a sodium channel blocker should be used. And this could be either phenytoin or carbamazepine. And again, here, over 90% of people agreed. So basically, these are the recommendations in neonates not responding to first-line anti-seizure medication. Phenytoin, levetiracetam, midazolam, or lidocaine may be used as second line, and the level of agreement was only moderate. If a channelopathy is presumed or suspected because of clinical and EEG features, then sodium channel blocker should be used, and if in any baby with a cardiac disorder, levetiracetam may be the preferred anti-seizure medication. When to stop anti-seizure medication? Again, this is a question which wasn't before evaluated in any of the other systematic reviews. We included 3 studies. One was prospective, 2 retrospective, but none of them were randomized controlled studies. And there's another study outside the time frame, and this wasn't a randomized controlled study either. This is a prospective observational study, which was just recently published in JAMA, but it was outside the time frame, so it wasn't included in the systematic review. So because of lack of evidence, we did a Delphi, and basically, we all agreed. I mean, we had a high level of agreement. Nearly 90% of us agreed that following cessation of acute symptomatic seizures, either electroclinical or electrographic, without evidence for neonatal onset epilepsy, so if the seizures respond to treatment and there's no other evidence for epilepsy, anti-seizure medication should be discontinued before the baby's discharged home. And this is regardless MRI and EEG findings. Effect of therapeutic hypothermia on neonatal seizures. We included 9 studies, 6 were prospective, 3 retrospective, and 9, but no randomized control trials. But these 3 could be upgraded because of their methodology, so that we could do great, even though it's low evidence, a low certainty. 2 were with below a low certainty. 1 was with also 2 were with very low and 1 with low certainty, but there is some evidence, at least, that therapeutic hypothermia reduces seizure burden. We also did a Delphi, obviously, and here we agreed, in over 95% of us agreed that therapeutic hypothermia may reduce seizure burden in babies with hypoxic ischemic encephalopathy. But it has to be remembered that the studies were that therapeutic hypothermia is used for HIE rather than as an anti-seizure treatment. Number 5 is the reduction of electrographic seizure burden associated with improved outcomes. So should we also treat electrographic seizures or only clinical seizures? We included 10 studies. 2 were randomized controlled studies, and actually this 11, 6 prospective and 3 retrospective. The problem is that all those 2 randomized controlled studies were all underpowered, and so we're not really addressing the question, and so no grade could be done. There was also another randomized controlled study which was published last year, but again, it was underpowered and really doesn't address the question at all, because I'll come back to that. So we did a Delphi, and actually we are in this expert group, we had a moderate level of agreement that all of us thought we should treat electroclinical and electrographic only seizures the same to achieve a lower seizure burden, and that a reduction of seizure burden is associated or may be associated with an improved outcome. So just very briefly about those 3 randomized controlled trials. All of these trials treated detected seizures and treated half of the babies with where they all grouped according to diagnosis. So half of them were only treated if they had clinical seizures, and half of them had EEG or AEG diagnosis and were treated if they were having electrographic seizures. The problem, as I said, was clearly underpowered in this study from Utrecht and also in this study from the United States. So therefore, those 2 could really not even address the question. In the Hunt study, which was also underpowered by more than, they had just over half of the babies they needed. But the biggest problem with the Hunt study is that they compared they didn't really compare babies who had a reduction of seizure burden. They just looked at whether babies treated or receiving medication versus baby not receiving medication were any better. The problem is that only 20% of their babies responded to treatment. And so we don't really know whether successful treatment improves outcome or not, as they had a very, very low response rate. And the reason for this is probably because they treated very late. The mean inclusion time for into this study was 26 hours. So if we think about HIE, the seizure onset is around 8 hours. These babies were beyond their maximum seizure burden, and any treatment would, it's just far too late. So I think looking at these randomized controlled trials, we can't really know whether treatment of electrographic seizure burden is needed or not. And at the moment, experts agree that you should treat seizures whether they are electroclinical or electrographic. Finally, the last one is pyridoxal 5-phosphate, pyridoxine and pyridoxal 5-phosphate. There were no randomized controlled trials, so we only did a Delphi. And we agreed that a trial of pyridoxine add on to anti-seizure medication should be attempted in all neonates presenting with EEG and clinical features suggestive of vitamin B-dependent epilepsy, and in neonates which are unresponsive to second-line anti-seizure medication without identifiable etiology. And here the level of agreement was high. We also had an additional recommendation. So without systematic review, we asked whether experts agreed that there should be a standardized treatment pathway, and we 100% agreed. We also suggested a treatment plan, which I'll show you in a second, and 74% of us agreed with that suggested treatment plan. And then we did a Delphi asking for need for communication with parents and guardians, and again, nearly 80% agreed. So this is our suggested treatment pathway, which is really all the points I've made with the special considerations for first line and second line, and include pyridoxine and channelopathies. And then this is just the recommended dosages and side effects. And so in summary, phenobarbital is currently the recommended first-line drug, but obviously short-term, as short as possible, and medication should be stopped if treatment was the baby stopped having seizures and there's no evidence for epilepsy. Second-line drugs can include levetiracetam, phenytoin, midazolam, or lidocaine, and there's no evidence which one is preferable. Prophylactic treatment beyond the neonatal period is definitely not recommended, and we clearly need more randomized controlled studies to evaluate anti-seizure medication for neonates. And I just wanted to acknowledge the whole group. This was a huge amount of work and very much a team effort. Thank you. So I don't know whether you want to go to questions. I also have a few cases which we could discuss, but that I leave this to you. So I've got 4 cases where we could discuss what the best treatment would be.
I think we have still time. It is 2:39. If you want to go through your cases,
Okay.
and we can do it first, and after that we can answer the questions.
Okay. So I'll start very, very simple. This really just tells you how to use this these guidelines. So here is a baby born at 41 weeks, was initially well, and then readmitted at the age of 4 days with drowsiness, not feeding, then developed apnea, and was intubated, and now is having seizures. So if you look, you can see seizures here, focal clonic. But when you speak to the nurse says she has also seen the left, so here's the right foot. She has also seen focal clonic or similar movements of the left hand. So what would be, first of all, what kind of seizure type is it? So these are focal clonic seizures, but they're probably multifocal rather than focal. What would be first line treatment? I mean, that is sort of phenobarbital anyway. So we have first line phenobarbital. Second line, what would people use as second line? I guess that really depends. The results of this of the septic screen came back, and the baby had a strep B sepsis. So it's an infection. There's really no contraindication for any of the drugs. So you could use levetiracetam, midazolam, phenytoin, or lidocaine. The baby was treated with phenytoin and responded to treatment. So and then when to stop, obviously these are acute symptomatic seizures, so you should definitely stop before the baby is discharged home. Here's another baby. So this is a baby born at 38 weeks with a congenital heart disorder, a crisscross heart. He had surgery at the age of 4 days and then needed ECMO postoperatively. And then after ECMO was stopped, he developed these seizures. If you look at his hand, you can see very discrete focal clonic seizures. So focal clonic seizures in this baby, they were always over the right side or right hand, which makes it very likely that this was stroke, and an MRI of the head confirmed that the baby had a stroke. Okay, first choice, obviously, would be phenobarbital. However, this baby had levetiracetam as first-line medication because the cardiologist thought that was the right thing to do, and the baby did not respond to phenobarbital. to levetiracetam. So, but in theory, really, the baby should have had first phenobarbital. Second line, what should be the second line? If you had phenobarbital, it should be levetiracetam because it's a cardiac baby. Now the baby had first line levetiracetam, and then we the recommendations was obviously to start the baby on phenobarbital, and the baby responded straight away to the first dose of phenobarbital and didn't need any further anti-seizure medication. When to stop medication? Do you stop this baby on discharge before discharge from the hospital? Obviously, the MRI is not normal. The baby had a big stroke, but it's still acute symptomatic. And so the new guidelines say you should stop medication independent of EEG or EMG or imaging findings if the baby responded to treatment, and the baby had responded. So he became seizure-free on phenobarbital and was discharged without medication, and seizures did not return, not yet. I mean, he's now 9 months old. Okay, next baby. This is a baby who was born at term, uncomplicated pregnancy, normal birth, with a seizure onset at 4 days. And so this is his seizure. So here you see an onset with focal or asymmetric tonic posturing. Then the baby stops breathing, becomes apneic. Somebody's going to give him oxygen in a second. This baby vocalizes a bit. And then if you look at his mouth, you can see really marked oral automatisms. And then tonic posturing of the other side. And at the very end, some clonic movements. So this is a seizure where you don't have a single clear predominant manifestation. And this is what we call a sequential seizure. So you have a sequence of different manifestations. First tonic, then autonomic, then automatisms, then tonic again, and then clonic. And this is a typical seizure type. Well, first of all, what the baby was mildly encephalopathic. The baby also had an MRI, an ultrasound, which were all normal. What would be your first choice? As there is no family history.
Blocker. A sodium channel blocker.
A sodium channel blocker. Good point. But the baby has no family history. So the guidelines would still recommend to use phenobarbital first. And the reason for this is because I fully agree, this is very likely to be either, it's very likely to be a channelopathy and need sodium, either phenytoin or carbamazepine. But if you don't have a family history, we recommend to use phenobarbital first line anyway, because until you have a normal MRI and a normal ultrasound and an EEG that suggests this diagnosis, this would cost you too much time. So try phenobarbital first, and then second line, definitely a sodium channel blocker. So this is the interictal EEG before seizures. So you can see the child has, the neonate has multifocal discharges, mild excess of slow possibly. And this is the post-ictal EEG with burst suppression pattern. So clearly in keeping with a channelopathy, and the baby was first treated with phenobarbital, not responding, had then carbamazepine and responded really well. But in order to not lose so much time, we recommend to use phenobarbital first and then your sodium channel blocker. Okay, and this is the last baby. So here, this baby was born at 40 weeks with mildly abnormal APGAR. So 3, 5, and 7 requiring resuscitation, was diagnosed with mild to moderate HIE and had seizures from the very beginning. And the seizures, this is a bit later, but I don't have a video from the very beginning. And you can see these are the seizures that the baby had. By now, the baby's in status epilepticus, I mean, constantly having seizures. What is first line? What kind of seizures are they? So these are multifocal myoclonic seizures. Obviously, this is highly suspicious of an inborn error of metabolism. So first line would again be phenobarbital, but then you would go to pyridoxine very quickly with a presentation like this. Baby didn't respond to phenobarbital, and here's the EG. So here you can see the baby had a burst suppression pattern, and with each burst, one of these myoclonic jerks, and then also focal clonic seizures. And then the baby received pyridoxine IV, and this is what happened. So there is a complete suppression of all EEG activity, but also of the seizures. So the seizure, obviously the baby responded and became seizure-free within a minute. But together with the suppression of the EEG, the baby also started having apneas and then a complete respiratory arrest. And this is something you can see. So it's the idea is that there's a GABA surge and therefore a complete suppression, which also often includes apneas, prolonged apneas, and rendering the baby ventilator dependent. And then the next day, so luckily the baby was put on the ventilator. This is next day, the baby was breathing spontaneously again, and the EEG activity has returned, and the baby was still seizure-free. So this is like a proof of concept, but it's something you should remember if you have, if you give pyridoxine, that you give pyridoxine and are able to ventilate.
Great talk. Thank you so much. And great cases also. And we have some questions in the chat box. But before that, I want to ask you, I have a couple of questions myself. And the first one regarding the treatment for the provocative or acute seizures. The recommendation currently is discontinue the treatment. But I don't know, sometimes, I think it depending on the case, we should evaluate case by case. But what you do in your clinical practice? So always you stop it, or what is your clinical approach?
Good question. And of course, I mean, these are recommendations and you have to look at case by case. I think if it was truly acute symptomatic and the baby responded to first or second line medication, then I would always
We lost you.
I think we lost connection. Ronit, can you hear us? Ronit? Okay, so let's see if she's gonna log in. Ronit, can you hear us? Okay, so we lost the connection. What we can do, and I'm gonna look at our chat box.
Try to send invite again to her.
I think most likely she's trying to log in, so maybe we can wait 1 or 2 more minutes. Here you go. She's back. You are back. Thank you for coming back. So,
somebody removed you from the meeting, it said.
sorry about that.
But it could be my internet. It has been flaky all day, so I don't know. Sorry about this.
Okay, no problem. Yeah.
So basically, I don't know where I cut off. So definitely individual is, I mean, according to each baby. But if a baby responded to first and second or second line treatment, and it was clearly acute symptomatic, so vascular infection or HIE, I would always try to stop. Of course, only if the baby responded to treatment. If the baby still has seizures, even if the baby has electrographic seizures, you can't stop, and then the baby has epilepsy. So you can assume that if a baby has still seizures after 7 days after the insult, you should consider this as epilepsy and not as acute symptomatic anymore.
Yeah, the chat box, there's a comment, I think, from Monica Naik. I think she's not with us currently. She left, and their approach is a little bit different also. And she was talking about the HIE patients. The first treatment, they use the phenobarbital, but if there is symptomatic seizures, if there is EEG background abnormalities, and especially if the background shows the sharp waves, they use levetiracetam. So this is a little bit different than what we do.
I would never treat the EEG. I mean, just sharp waves in an EEG is not a reason to treat. You need to really have seizures rather than an abnormal EEG, because babies with HIE always have an abnormal EEG. That's just part of the HIE. So that's the first thing. I think I would always have a clear diagnosis of seizures. So you have an EEG, and if you have seizure discharges, clear discharges with an evolution of at least 10 seconds, then that's seizures and you treat them. But just an abnormal EEG is probably not a good indication for treatment. But I would also stop any baby with HIE if they responded to 1 or 2 drugs. The GLASS study has clearly shown that treatment with beyond outside the neonatal period, sort of prophylactic or continuing medication, does not reduce the risk for epilepsy. They had a big group of patients and babies where treatment was continued outside the neonatal period. So after they were discharged, they had the same risk of having epilepsy later and learning difficulties later. Stopping medication doesn't increase by any means the risk of epilepsy. And why would you then continue medication? Because, I mean, all medication have side effects. Phenobarbital, you treat, if there's a benefit if you treat something, but just giving it out of without any evidence that it is helpful, we shouldn't.
Our practice, we start with loading dose 20 per kilo. If baby continuously having seizures, we give additional loading doses. And what is the maximum dose you recommend? So we couldn't hear you, Ronit. You are muted.
Sorry. Okay, so the recommendation is to give 20 as you do, and then another 20 if the baby is ventilated. If the baby is not ventilated and there may be issues about, I mean, depending on which setting you are, then like in low and middle income countries, we recommend only 10 additional, because then obviously if you give 20, but not more than 40 milligrams as a load. So 20 plus 20.
So after the second loading,
Yes.
if there is seizure at the second medication, not.
So yeah. So
Don't
if you give 20 and then another 20, and then you go to second line.
Second line. Okay.
no
good
more
to
than
know.
40.
Okay. So there is a question about preterm versus term infant seizures. Is there any difference in the implications and response to treatment between seizures in preterm and term infants?
Good questions. We don't know. There are no studies. No idea. It's definitely something. I mean, phenobarbital is still, studies have shown that it's effective in preterm babies, but there's just not enough data to make a clear differentiation.
And there is another comment. Can you show us the treatment algorithm slide once more, please?
Sure. I can also send you the, I suppose, I don't know, but yes, of course. Can you see? Am I sharing?
No, no, we couldn't.
Okay. Well, hold on. Share. Oh, there we go. So this is the
Okay,
pathway.
perfect. Mhm.
And actually, the guidelines are available on the ILA website, but this is the version, the first version before we implemented the comments from the public consultation. But it's more or less the same. And then and this here is the dosages.
Dosages, yeah. And there is another question. How do you define cardiac disorder? Avoiding phenytoin structure, rhythm, or dysfunction post-hypoxia?
Yeah, I mean, any baby with a congenital heart disorder, basically. Or if a baby has arrhythmias, then I would also not use phenytoin or lidocaine.
So there is another question about the extension of EEG without clinical symptoms. Could be the absence seizure. We need to, hold on a second, when we have extensive EEG seizure without clinical symptoms. Could be.
So I don't really think we should treat seizures any differently, whether they have a clinical manifestation or not. I mean, if you think about it, on ITU, adults also often don't have clinical seizures. We give these babies are critically ill. They are sedated, they are ventilated, they're on pain relief, they might be muscle relaxed. So the reason why these babies have no clinical manifestation is mostly because what we do to them. We treat them and they become electrographic only. So I don't think at the moment we have any evidence that we should treat clinical seizures any differently or any more aggressively than electroclinical seizures, electrographic seizures. I make no difference. Electrographic seizures I treat just the same as clinical seizures.
Yep, thank you. And I think that we have one more question. Thank you for your great presentation. How should we manage anti-epileptic drugs for infants receiving multi-drugs due to intractable epilepsy regarding the drug-drug interactions, drug metabolism? Well, this is a tough one.
So to be honest, this is really a question for the epileptologist. This is something you will not encounter on the neonatal unit, really, because by the time the babies, if you have a baby with epilepsy, then it becomes very difficult. And obviously, like similar to in older children, you should avoid polytherapy. So if a baby doesn't respond to the first drug, you should stop the drug and go to the next, not add on one after the other. It's never a good idea to have a baby on more than 2 medications. So if one drug doesn't work and the baby still has seizures, stop one and give the other one, or give the other one and then stop the one before, rather than adding one after the other. That also helps you with the the problem of multitherapy and in drug interactions.
And I have
Hi,
last question.
Ronit.
Oh, Dr. Pestana Knight, she's the neurologist here at Cleveland Clinic. Hi, Dr. Pestana.
Hi, how are you, Seda?
Good,
Thank you for hosting Ronit. Hi, Ronnie. So good to see you. It's always
Good to
a
see you.
pleasure to hear you. So I sit on the epileptology side, right, of the problem. I first meet the babies through the EEG because the neonatologists and the pediatric neurologists are providing care, right? And then I meet them afterwards, right?
Yes.
So if we want to have an algorithm that will work for everybody, whether you have resources or no across the world, I think that phenobarbital is the best drug. I think that we have proven again and again and again. But when I sit with the book of seizures, whether they are EEG seizures and clinical seizures, right? And etiology. So by the time that I get the patients, I already know the etiology because the MRI have been done. Whether it took 3 days to a week to get it done, is done, right? By the time that I see them. By then, the whole story of the status have unfolded, where they respond to first line, second line. In my eyes of epileptologists, and putting together what we know of genetic epilepsies and neonatal onset genetic epilepsies, to me is more cost effective in my eyes, is the patient have a family, a tonic seizures, whether there is a family history or not, to go with a sodium channel blocker to save time, because we know that tonic seizures are very rare to start with.
I agree. But as you said, by the time you are asked, the baby has hopefully already had first-line medication because you're not asked with the first seizure. So that message to use phenobarbital first, regardless what, is really for the neonatologist. First seizure, you give phenobarbital. And then if they don't respond and then they get you, then of course you use sodium channel blockers. Of course.
Yeah.
And I fully agree.
Yeah.
Tonic seizures are very suspicious, but you have also other genetic causes, not only sodium channel channelopathies, which have tonic seizures.
Yeah, no, absolutely. Yes, thanks God for the pyridoxine, right? So now
Sure.
I have more than 20 years of giving pyridoxine to kids who don't respond to the first, second line of medication, but I have found 2 pyridoxine deficiency on my career.
Absolutely.
So how many to treat to get there? I almost say that it's more cost effective to send the genetic testing quickly the minute that I have a clinical seizure and an EEG that is suspicious, with the current turnaround that we have, than going through the whole process of all the medication that most likely are going to fail.
Absolutely.
Yeah, but thank you for all the work you do, and thank you for sharing your afternoon with us.
Thank you.
Actually, it is evening, I think, now in England, right? It's not afternoon. Yeah. Yeah. Great discussion, great presentation. Thank you so much.
Thank you very much.
Yeah.
It was a real pleasure.
Dr. Akun mentioned that we are revising our protocol for the treatment of neonatal seizures, and I'm very pleased to see that it's very much aligned with the current guideline recommendations.
Excellent.
Yeah, we are.
Do we have time for another question from me?
I am sorry, what was the question?
Oh, I was going to ask if there's time for one more question.
Sure.
Yeah. Dr. Pressler, it's okay?
Of course.
Yeah, sure.
Oh, thanks. My name is Daphne Porat. I'm one of the pediatric neurology residents in the program, and I'm working with Dr. Pestana on revising our protocol, and we were definitely using the guidelines that you were discussing. So thanks for your work. I wanted to ask, practically how much pushback have you been getting about discontinuing anti-seizure medications prior to discharge from the NICU, and trying to implement that change? And also practically, how have you been doing it with like babies still hooked onto EEG or not? And like, what's your practice and like the process of peeling off the medications?
Yeah, good question. So it really depends how many medications the baby is on. If the baby is on phenobarbital only, you can just stop, and that's fine. Because the half-life is so long, there's no need to withdraw gradually. But if a baby is on phenytoin, phenobarbital, and midazolam, for example, then there is definitely, I mean, you can't stop everything together. You have to taper slowly, and midazolam definitely has to be tapered anyway. You can't stop midazolam straight away. I think if you have a baby on 2 medication, then you stop first the one which didn't work, and then finally the one which worked, with 1 or 2 days in between.
Dr. Pressler, we couldn't hear you. You are muted again.
Yeah.
Okay, yeah, we
Normally,
can hear you now.
By that time, the baby is not really, usually the baby is a few weeks old, and so then most seizures become electroclinical, and the risk of, so the baby's not an ITU anymore and not critically ill, because that's the moment when you stop medication, and then the risk of electrographic seizures is much less. But of course, if you can do EEG by the time you have withdrawn all medication, that would be preferable. And we usually do 1 EEG before discharge, just to make sure.
I think the chat box, the one more thing, and I want to actually ask you. So they are asking, do all your patients have continuous EEG monitoring as testing modality? May not be available at all centers also.
Yeah.
And it's true.
Yeah, I mean, it's a very sore point. I wish we have, but the NHS has no money for EEG monitoring. So even in my hospital, most children have 1 hour EEG recordings, and only the babies who are really at very high risk or where we suspect seizures have 24 hours of EEG monitoring. I did a survey in last year or 2 years ago to see how many neonatal units in the UK actually have the option of 24-hour EEG monitoring. And it's really quite sad. Only 5% of all neonatal units in the UK can ask for EEG monitoring. All the others only have routine EEG and AEG. And that's definitely a problem. I mean, this is something we need to work at.
Okay, it looks like we don't have any more questions. Again, thank you so much. Great presentation.
Thank you very much. Take care. Thank you. Bye.
Yeah.